Hi, my name is Megan Hall. I am Vice President of Medical Affairs at Grail, and I am excited about the opportunity to talk to you about Grail and multi-cancer early detection. So I don't think it will come as any surprise that detecting cancer early can dramatically improve cancer survival, and that's evidenced by the numbers on this slide, where survival is almost 90% when that cancer is diagnosed at an early stage before it is spread, and that drops to about 21% when the cancer is diagnosed at a later stage after it has spread. The problem is that we don't have a mechanism to detect the vast majority of cancers at earlier stages in asymptomatic patients. 70% of the deaths that occur in cancers are in cancer types that don't have a recommended screen. Only 30% of the deaths are in cancers with one of the big 5 recommended screens: breast cancer, colorectal cancer, lung cancer in high-risk patients, prostate cancer, and cervical cancer. So we really need a mechanism to detect more of these cancers at earlier stages and extend the benefits of those single cancer screens to the majority of these cancers that don't have a recommended screen. What this translates into is an enormous human and economic toll from cancer in millions of years of lost lives, billions of dollars in the annual cost of cancer, and over $1 trillion in overall economic burden. So Grail sees a better way. We really need to shift away from screening for individual cancers to also screening individuals simultaneously for multiple cancers. We need a way to detect multiple cancers that will complement, not replace, the existing single cancer screens, that will optimize the overall cancer detection in the population, and that will minimize harms. Grail was birthed after, partially after an initial insight that there was a shared cancer signal that was seen in circulating DNA in women that were pregnant women that were undergoing non-invasive prenatal testing. There were 10 cancer cases found in over 125,000 tests. These women had an abnormal non-invasive prenatal test, but a normal baby. And that they ultimately went on to be diagnosed with cancer. And it was the first recognition that there is this kind of common or shared cancer signal in circulating DNA that could then be leveraged potentially for a multi-cancer early detection test. And that's exactly what Grail has done. We were founded in January of 2016 to take on what we see as one of the world's biggest challenges, which is to detect cancer early when it can be cured, which is really our best chance to bend that cancer mortality curve. We have a broad and deep set of partners, as is evidenced on this slide. And this is not a complete snapshot, but it is just a list of some of our highest profile partners. And I wanted to walk you through the process overview for our multi-cancer early detection Gallery test. And then we will back out and start talking about the vast amount of data that we have that supports this test. So the test, tumors shed DNA into the bloodstream, and those tumor DNA fragments carry epigenetic or genetic alterations that are indicative of both the tumor type and the tissue in which they originated. We can isolate the plasma that contains those cell-free DNA fragments, subject those DNA fragments to a targeted methylation analysis. So we are looking at a very efficient methylation-based assay. And then we subject the results to a machine learning classifier, and there's a binary result of either no cancer signal detected or a cancer signal detected. And if we detect a cancer signal, it will predict where in the body that cancer signal is coming from. And that's really important for directing the downstream diagnostic workup. So what's the rationale for multi-cancer early detection? Well, first, I mentioned that tumors shed nucleic acids into the blood and other body fluids, and they carry cancer-specific information. On the right, you see 3 different types of cancer-associated aberrations in cell-free DNA. Those include mutations, which are pretty commonly associated with cancer, chromosome alterations, and also DNA methylation patterns. Those methylation marks specifically distinguish cancer from non-cancer and provide a cancer signal origin. They really act as a fingerprint for where in the body that DNA fragment is coming from. And Grail, from this data, has built a database to teach our machine learning classifier to distinguish from among these patterns for both non-cancer and cancer, but also the where in the body does the cancer come from. Importantly, multi-cancer tests benefit from aggregate prevalence and a single specificity. So the specificity is not cumulative. And there's this aggregate prevalence that increases the positive predictive value. So PPV is the probability that a positive screening test indicates the presence of cancer. It increases with test specificity as well as with cancer prevalence. So aggregating those prevalence rates is going to yield much higher PPVs than single organ screening approaches. And that's evidenced in the graph on the right, which was adapted from a really nice paper that was published in 2018. More recently, cancer screening randomized controlled trials have also supported a multi-cancer early detection approach. I mentioned the cumulative incidence of false positives. That's the plot on the right. That's from the PLCO trial in this third bullet point, where the cumulative risk of a false positive after sequential single cancer screening tests was 50% or greater, which is really quite high. Now imagine that as a series of single cancer tests building up to a multi-cancer test, and that false positive rate is going to become intolerable. Additionally, more deaths have been recorded due to other cancers than the one being screened for in a handful of other trials as well. So how do we evaluate a multi-cancer early detection test? We want to make sure that the test is detecting many lethal cancers, including those that don't have screens, using a single blood sample that's collected at point of care. We want to be able to predict the signal origin to direct the diagnostic workup. That's a really important feature. We want to make sure that there's large scale and very robust clinical validation. And then we want to have a high specificity. We really want to limit the false positives so that we restrict the number of unnecessary workups. And importantly, MCEDs are a complement to existing screens, not a replacement. So now let's talk about some of the Grail clinical studies. This is a snapshot of our overall clinical program. We are enrolling more than 335,000 participants. About 3/4 of these have actually already been enrolled to our trials. We have 8 hallmark studies, and I'm going to talk more deeply about 2 of those studies, the CCGA study and the Pathfinder study, both of which were used to develop and validate the Gallery test. These 2 studies include more than 21,000 participants in a case control and an interventional study, and I will talk about those in a little bit more detail. So the Circulating Cell-Free Genome Atlas study is a prospective, observational, longitudinal case control study. It was divided into 3 specific sub-studies using mutually exclusive sets of patients, and the goal of CCGA was to discover the best assay to use for multi-cancer early detection, and then to train and validate the assay and the classifier for a multi-cancer early detection test. The first CCGA substudy on the left compared methylation patterns, mutations, and chromosome alterations, and found that methylation patterns outperformed the other two assays, both in cancer detection and cancer signal origin, and had one of the lowest limits of detection and the most opportunity for efficiency improvements. And so methylation was moved further into development in the second CCGA substudy, where we developed and trained a machine learning classifier to differentiate cancer from non-cancer and to predict cancer signal origin. And then in the third CCGA substudy, we did a large-scale clinical validation with a refined version of that assay and classifier to support the Gallery launch. So I'll talk about the third CCGA substudy because this is a study in a clinical validation in more than 4,000 participants. First, I want to highlight that the sensitivity varies pretty broadly by cancer type and by shedding rates, which I'll come to in a slide or two. And you can see that cancers range from very low detection all the way up to very, very strong detection. I will note that this is stage 1 through 4. When we look at by stage, we see the same pattern, very broad variation across these different cancer types. And you'll note that some of the more aggressive cancer types tend to be the ones that get detected much better than the potentially more indolent cancer types like thyroid and early stage prostate cancer, for example. So there's a biological driver of this detection, and there's 2 points on this. This is a plot of tumor fraction by clinical stage for cancers with high mortality versus low mortality. And there's 2 important points. One, as expected, tumor fraction increases with stage, so that later stage cancers are going to have more cell-free DNA available and makes them inherently more detectable by the assay. But importantly, cancers with high mortality also have a higher tumor fraction even within stage. than cancers with low mortality. So what that means is that more aggressive cancers are shedding more DNA into the bloodstream. That makes them more detectable by the assay. And that's why you see differences in detection rates. What that translates to is actually prognostic information as well. And so cancers that are not detected by the MCED test, which are colored in blue, actually have a much better prognosis than cancers that are detected by this MCED test. So that's one really interesting point. The other really interesting point is that if you look at cancers that are not detected by the assay, look at stage 4, and compare to what we might expect their survival curve to be based on SEER, you can see that there's a really big separation in those curves, which suggests that there's some biological driver of detection that is making the cancers that are detectable, or the much more aggressive cancers that are detectable by the assay, are the ones that we are picking up. So this is a summary of the key performance features from our third CCGA substudy. Again, this is a 4,000 person clinical validation. We had a 44% modeled positive predictive value. To put that in context, PPVs for single cancer screens tend to be in the single digits, so we're about 10-fold higher. This is modeled because this is a case control study. We have an extremely low false positive rate. Again, that's really important for population scale implementation. And then a range of sensitivities based on what data cut you're looking at. So 41% overall for stages 1 through 3, all cancers, and then 68% if you just look at 12 pre-specified cancers that represent 2/3 of the cancer mortality. And importantly, we were able to detect a cancer signal across more than 50 cancers, which are listed on this slide here. We also, when we call it cancer, we are able to predict that cancer signal origin almost correctly almost all of the time. So I'm going to shift gears and talk about Pathfinder. This is data that was debuted at the ESMO meeting earlier this year. Pathfinder, that was all case control data. We need to understand how the test works in the real world in an intended use asymptomatic population. And that's really what Pathfinder was designed to do. It's a prospective multi-center interventional return of results study in adults who were at least 50 years of age or enrolled from 7 sites around the US into 2 different cohorts, one with additional risk and one without additional risk. All healthcare providers and patients had the reports returned to them. If there was a signal detected test result, then the physician worked with the patient to get to a diagnostic resolution of either cancer or no cancer, and then we reassessed cancer status at 12 months. If there was no signal detected, then cancer status was assessed at 12 months. This study was initiated with an earlier version of the assay, and so you'll note there's a pre-specified reanalysis of blood samples with the refined version of the test, and I'll come to that in a few slides. This is a summary of the Pathfinder study population. So adults 50 years of age with and without additional risk factors. So cohort A is the with additional risk. So history of smoking, not surprising, genetic cancer predisposition, and prior cancer treatment that was completed at least 3 years ago, and this excluded adjuvant hormone therapy. Cohort B was the without additional risk, so participants who are at least 50 years of age without any of the additional risk factors described in cohort A. The primary study objectives were really to assess the extent of diagnostic testing that was required to get to a diagnostic resolution after a positive or a signal detected test result. It's really meant as a safety and a clinical implementation study. We also added secondary objectives that looked at test performance. And so we looked at cancer detection, we looked at the signal origin prediction, and then we also did a very robust analysis of patient-reported outcomes and perceptions about this multi-cancer early detection test. So I mentioned on the earlier slide that we started this study, things move fast in the diagnostics world. So we started this study with the earlier version of the test, and then we refined the test for screening and then did a pre-specified analysis to reanalyze the blood samples for performance and compare to that early version to make sure that the refinements that we made were actually having the intended effect. So I'll start with the early results. So this is a high-level summary. This is basically the take-home messages from this study. We approximately doubled the number of cancers that were detected with standard of care screening. About half of those cancers, of the new cancers, were stage 1 or 2. So we're picking up a large proportion of very early stage cancers in here. Importantly, and I'll show you in a few slides, most of these cancers don't have a recommended screening test at all. And so to pick up stage 1 and 2 is actually really potentially impactful for those patients. Importantly, it was safe to implement this test. We had no adverse events due to diagnostic workups after a signal detected result. The diagnostic resolution was expedient, and keep in mind that this study was run almost entirely in the midst of the COVID-19 pandemic. And to have expedient diagnostic resolution in that setting suggests that in a post-COVID world, if there is such a thing, that we would have even more expedient diagnostic resolutions. The prediction of cancer origin, really importantly, was very directive for the healthcare providers in their clinical workup to get to a diagnostic resolution. The invasive procedures that patients underwent after a positive test result were reassuringly more common in the true positives than they were in the false positives. And the early test version really led to relatively few false positives, so high specificity and high PPV. And together, this really supports the feasibility of this test for broad screening use. So let's dive into this a little bit more deeply. So this is a summary of the performance characteristics from the earlier version of the test. A cancer signal was detected in 1.4% of participants, which is about what we would expect based on the SEER. If you compare to SEER, that's about where we would expect to be. And in this intended use population, the overall PPV was about 38%. And keep in mind, let's put that into context with respect to those single cancer screens. So for mammography, for example, the PPV is about 4.5%, which means that out of every 100 women with a positive mammogram result, only between 4 and 5 actually go on to have cancer. Here we're almost tenfold higher than that. And again, that harkens back to the benefit of that aggregate prevalence that I showed you a few slides ago. We approximately doubled the number of cancers detected with standard of care screening. So if you focus on this bar on the left, there were 29 cancers in this population that were detected from one of the 5 recommended screening tests in the United States. We had an additional 35 cancers that were detected with this multi-cancer early detection test. So we're more than doubling it compared to the standard of care recommended screens, and we approximately double it when you consider non-standard screening like melanoma and thyroid cancer screening. The diagnosis was expedient. And again, I want to highlight that this all occurred during the COVID-19 pandemic, in the midst of it. So the median time to diagnostic resolution was, not surprisingly, longer for false positives than for true positives. Of the true positives, about 3/4 of them reached a resolution in less than 3 months. And compared to what we see, there's not a lot of literature on time to diagnostic resolution, but what is available suggests that this is actually a really efficient time to diagnostic resolution. Half of those true positives were actually diagnosed in 2 months or less, which is really impressive. And again, in a post-COVID world, we might expect those timelines to pull in even a little bit more. And in the false positives, there were planned reevaluation intervals, as you might expect, of 3 months or longer. And that just happened to be more common in the false positives as they're undergoing workups and rescreening and retesting, which is obviously likely reflecting repeat or scheduled follow-up testing. So looking at the invasive procedures that confirmed a cancer diagnosis, most of these were happening in true positives. And I want to just highlight the definition of an invasive procedure here. We have non-surgical invasive procedures, which was the vast majority of the invasive procedures that were undergone. These are like endoscopies, FNAs, core biopsies, and then we have surgical invasive procedures on the bottom. And you can see in the non-surgical invasive procedure, the vast majority of these are actually non-surgical invasive procedures, and more common in the true positives than in the false positives. Most invasive procedures were actually directed due to, or were a result of, an abnormal finding. So this top row is the percent of participants with an invasive procedure that was triggered by abnormal imaging, laboratory, or physical findings subsequent to the positive test result. About 80% of the true positives and 18% of the false positives had their event triggered by abnormal imaging, laboratory, or physical findings. This slide represents the cancers that were diagnosed after a true positive signal from the test. So we diagnosed 36 cancers in 35 participants. The cancer types that are listed in blue are the cancers that do not have a recommended screen. So there's no mechanism for these cancers to be detected asymptomatically as part of a screening program, for example. There were 27 cancers that we identified that have no recommended screening. They're not routinely screened for, which suggests a huge potential benefit on a population scale. Importantly, we had no adverse events due to the diagnostic workups after a signal detected test result. The only adverse events that were reported were 4 study-related AEs, and 2 of them were related to the FLEB procedure itself. 2 were related to the test before the test result was returned. So anxiety, no events were severe and all of them resolved. And again, no significant adverse events reported due to the diagnostic workup. So importantly, the test can be safely implemented in an intended use screening population. So I mentioned that was the earlier version of the test. We'd made some refinements as we started, things move fast in diagnostics. And so as our machine learning classifier is learning, as we are learning, we made some refinements to the test and then did a pre-specified reanalysis of all of the samples from Pathfinder with the refined version of the test. Importantly, the refined version of the test, the results were not used to communicate results back to physicians or patients. That wasn't a part of the protocol, but we were able to look at some of the performance characteristics of the test, and that's what I'll talk about here. So again, that's highlighted in red here. This is the pre-specified reanalysis with the refined version. So what adjustments did we make? There were 3 specific adjustments. We increased the specificity threshold for hematologic signals, and that was specifically because we wanted to reduce the number of false positives we were seeing, or the number of cancer-like signals that we were getting from really prevalent non-malignant hematologic conditions. And we wanted to be able to detect additional solid cancers. And so we adjusted the threshold for the heme cancers to make it a little bit more challenging. We removed what was called an indeterminate cancer signal origin class. So what happens now is that every cancer signal detected test result gets a cancer signal origin prediction with it. And that is specifically to give physicians very clear options for their diagnostic workups. And then the test report, was originally a report that included a large number of cancer signal origins. And we found that that was actually not very helpful for the physician. And so we reduced the maximum number of cancer signal origins that is included on the report to 2. And again, pre-specified analysis. So this slide depicts the rationale for adjusting the hematologic cancer threshold. This is the over half of the first cancer signal origin predictions were hematologic. And so you see this big bar of lymphoid neoplasms here. You have 58% of these first CSO predictions were either lymphoid or plasma cell neoplasm. And we actually had a surprisingly low number of colorectal and lung predictions, which could be a result of this threshold issue. It's also likely a result of the population that Pathfinder tends to include a very heavily screened population as well. So did those adjustments result in the performance improvements that we wanted to see? I can say very clearly, yes, they did. So we saw a drop in our cancer signal detection rate from 1.4 to 0.9%. The vast majority of those cancer signals, the difference is largely due to hematologic, pre-malignant hematologic conditions. So those false positives actually dropped quite a bit. That resulted in an increase in our specificity, as well as an increase in our positive predictive value. This is a high-level summary of the key performance features of Gallery from the Pathfinder test. So this is the refined test, which is the version that supports Gallery. We had, again, a 0.9% cancer signal detected rate. We had a 99.5% specificity, so our false positive rate is 0.5%. We have a 43% observed positive predictive value in this population. The accuracy of the top 2 cancer signal origins was almost 90%. So again, when we call it cancer, we get it right almost all of the time. We had about 2/3 of the cancers that were detected were stages 1 through 3. So largely prior to metastasis. And about 40% of those new cancers were stage 1 and 2. Again, we're detecting a large number of early stage cancers that have no recommended screening test. And the cancer types that were detected are listed on the right here. And you can see that there are a large number of cancers, again, without any kind of screening test. So I want to come back to the CCGA-3 study for 1 minute. So that was a case control study, again, meant to develop and validate the test. And I mentioned at the start of the Pathfinder section, it's really important that we need to confirm that performance in an asymptomatic or screening population, an intended use population. And so I wanted to put these numbers side by side because I think they are really impressive. Our false positive rate, our positive predictive value, and our cancer signal origin accuracy translated almost directly, which really speaks to the rigor with which the test was developed through the clinical validation studies in our case control study, and to the potential that this test has for really broad population scale implementation. So what does this look like in the real world? Obviously, as we get more real world evidence, we will be able to analyze this using actual data, but this is modeling the potential impact of the Grail Gallery test when added to usual care. So adding it to standard of care recommended screens. Again, it's really meant to complement, not to replace. The tests are designed very differently, so I want to be very clear about that. But what is this going to look like? And I think there's a really exciting picture that's forming here. I think we're going to be able to increase the diagnostic yield. Our modeling suggests we're going to increase the diagnostic yield by 31%. We're 31% of cancers that are intercepted by an MCED test. We're going to be able to reduce the late stage incidence of detected cancers by about 50%. And most importantly, we expect to see about a 20% reduction in 5-year mortality from implementing this test in addition to the regularly recommended single cancer screens. So what's happening in the real world with Gallery? So this is the Gallery test in action. This is a summary of the first 35,000 tests that we have run through clinical practice through our commercial pipeline. Input. I have data on the next slide as well, but it's timely and successful delivery of results. It's helping to detect cancers that lack recommended screens. And we have a robust post-positive test clinical support available to help clinicians in their decision-making should they get a cancer signal detected test result. So what does this look like? Our overall cancer signal detection rate from the first 35,000, more than 35,000 tests that we have run is about 1.1%. I think that's about where we expect to be. That means the vast majority of the test results were negative, so cancer signal not detected. And in terms of the delivery of the test results, so almost 99% of the Gallery orders were issued a test result. There are some cancellations and other minor issues that happen here and there, but vast majority of Gallery orderers are getting their test result. We have an average 6.7 business days of turnaround time, and almost all of the test results are delivered within the promised 10 business days. This is the important safety information and laboratory test information that I will leave up for 1 minute before I go to the last slide. And again, at Grail, we see a better way than doing sequential single cancer screens. Those are all going to have a cumulative false positive rate. You're not going to benefit from the aggregate prevalence. We really have to shift our thinking away from screening for individual cancers and shift towards also screening individuals for multiple cancers. Thank you so much for your time, and I am more than happy to take any questions. So I see one question in the chat. Who do you see would be ordering those tests in the clinical setting, PCPs or oncologists? What is the role of the oncologist if someone has a positive test result? It's a really important question. So because this is meant as a screening test in generally an asymptomatic population, you would expect more primary care providers, potentially OB-GYNs, nurse practitioners to be ordering this test. And that's exactly what we see in the real world and who we've been doing deep levels of education with to make sure that they understand and are aware of not just how to use the test, but how to interpret the result, how to communicate with their patients, and what to do if they get a positive test. The oncologist is an interesting question, specifically because the oncologists tend to see the patients post-diagnosis. So actually in the continuum of care, what's happening is that a primary care provider will get, for example, a cancer signal detected test result. Assuming they refer that patient out for workup, then that patient goes to a specialist generally. So like a GI doc, if it's a esophageal or a colorectal cancer, upper GI or colorectal cancer, cancer signal origin. And then that GI doc would do the workup and determine whether there is a cancer diagnosis, and then that patient would hop over to the oncologist. So what we find is that we need to be educating our ordering providers, but we also really need to pay attention to that specialist audience as well, because we want to make sure that no patients are falling through the cracks as they're moving through that cancer care continuum. And so we have concerted efforts for education and outreach kind of across that cancer care continuum, culminating with the oncologist. I hope that answered your question. I see another question in the chat. In the Pathfinder study, how much of your invasive procedures were diagnostic versus therapeutic? That is a good question that I would have to go back and look at the data. And so I'm happy to follow up. If you're willing to share information, I would be happy to follow up offline. Happy to take any additional questions. One more coming in through the chat. Of the 6,600 patients, did all get routine screening tests like mammography as per their age and gender indications? In other words, was the MCED being compared to a group that was heavily engaged in the routine screening tests already? Yeah, that's an interesting question. So one slide that we didn't put up, I don't think it was in there, was a slide that shows the adherence to screening for this population. And it was an extremely adherent population, very heavily screened with very high rates of adherence to all of the screens, including mammography and colonoscopy. So there is a healthy volunteer bias in this population. And I think that's also evidenced in, like if you look at LDCT, for example, there was much higher uptake of LDCT than you might expect, including in patients who were not actually eligible for LDCT. So I think it's a very worried well population that we captured here, as you might expect for these kinds of clinical studies. So yes, heavily screened, very engaged in routine screening. And importantly, one of the other things that we didn't put in is that, we want to understand as part of our patient-reported outcome analysis, whether these patients are planning to continue to adhere to their recommended screens, if they get a negative test. And so what we find through that patient-reported outcome analysis is that patients self-report that yes, they're going to continue engaging with their regularly recommended screens, which again is really important because it's meant as a complement, not to replace. So the cost of the test, the list price of the test right now is $949. It is not yet covered by insurance, and we are very actively engaged in getting down a path where we can get coverage and do some cost reductions. One of the most important things to us, being a very patient-centric organization, is ensuring broad, equitable access to this sort of technology. So we're balancing that with, the current, where we are with the current cost and coverage issues, with the huge sense of urgency that we have around getting this technology out into the world now and building out that evidence package as we go to the payers, to try to get coverage. It is currently not covered by Medicare or Medicaid, to the other question in the chat. Are there any other questions that I can answer? One more came in. Are the demographics of the Pathfinder study population different from other studies evaluating single cancer screening tests? They are a little bit different in that obviously some of the big single cancer screening tests for mammography are entirely women. This is a co-ed population. Ditto with prostate cancer, that's going to be entirely men. This is co-ed. So I think there are also some key differences in terms of geographic spread. I think we have a very worried well population. Again, I think that is a common theme across all of the single cancer screening studies. You tend to get participants who are very engaged in their own healthcare and much more willing to participate in these kinds of trials. So what was the follow-up of the heme malignancies? So the heme, actually, let me back up. Each of the cancer signal detected test results, the follow-up workup was at the physician discretion. And so no workup looks exactly the same for each individual cancer signal detected, predicted cancer signal origin. So that said, we have a lot of information on heme malignancy workups, but there's a lot of variation in what those workups were based on the patient, the patient issues, as well as the healthcare provider decision-making. So it's a hard question to answer because there's a lot of variation in how they were worked up. But importantly, we wanted it to be physician discretion because we wanted to understand their decision-making through the process. And the take home, I know this isn't specifically addressing the question, but the take home that we found was, really importantly, that the cancer signal origin was actually very directive in like what tests they chose to do, and they found it very helpful for them. The next question, unfortunately, is, are you still enrolling if anyone is interested? Unfortunately, the study is closed. We've stopped enrolling a little bit over a year ago. And these are the end of study results after the 12 months of follow-up have completed. That said, we have a number of ongoing studies that are actively enrolling and would be happy to engage in a deeper discussion of that should you be interested, and I'm happy to have people reach out. One more question. If insurance has not approved this, if someone pays out of pocket and has a positive test, are the imaging, endo procedures, et cetera, covered by their insurance? Important question. So you're right. Somebody is generally it's paying out of pocket for the Gallery test. What we have observed to date right now, I think we actually have more than almost 45,000 tests that have been run. We've seen an extraordinarily low number of payer blocks in the single digits. And all of those payer blocks, have been for whole body imaging modalities. And all of those payer blocks were resolved with a letter of medical necessity. So we're optimistic that that pattern will continue and that insurance will recognize the importance and the urgency behind these results and continue to facilitate those diagnostic workups. And with that, I thank you so much for your attention. Appreciate the opportunity to walk through the data. As always, please feel free to reach out with any other questions. You can go to the Grail website at grail.com, or you can go directly to the Gallery website at galleri.com. Or I'm also happy to field questions directly. And thank you again. I really appreciate it.